And I'll read this first one. Yeah, I guess we'll alternate here. So tooth number 24 and 25, resorption and a large perio abscess that formed. The teeth were extracted initially without grafting because there was a lot of swelling, a lot of infection, and tissue quality was poor. So we can't really argue that.
How often do you do that?
Not often, but probably more often now than in the past. I used to sort of go for home run every time, thinking to myself, well, if I can get in there and if I have an opportunity, might as well take every opportunity as possible. I think the only drawback is that you end up now having to wait, right? You want to now wait if you graft 4 to 6 months. And if it doesn't achieve, complete, regeneration of what you were looking for, now you're kind of 4 months behind. Yeah. The alternative option is to extract, go back, and let's see what we're looking at in this case specifically. We'll go back a little bit. What we're looking at in this case is a very challenging defect that appears, following tooth extraction, obviously vertical bone loss. And if we just let this heal, then we're going to enter this site with better keratinized tissue, which is obviously a good thing for GBR. But I always have the issue of what am I actually removing? Anything that's soft, any of that baby bone that's there, there's always that factor in your head. Am I removing old infected tissue, or am I removing baby bone?
Exactly. If it's bone, you want to leave it. If it's scar tissue, you want to remove it. But how do you tell the difference? Not easy.
And now the other thing about this case, I really think this is a key treatment planning case. And I love that the person who submitted the case said, they brought up, yeah, sure, we could go for a 4-unit bridge. And that could be a tooth-borne bridge or maybe even a 4-unit implant bridge. And, I'm going to show an example of that where I was kind of faced with that decision myself. And to me, it's a no-lose situation because you're going to get better aesthetics, I think, with having, the 4 teeth done. But of course, when you start doing this and the patient had 2 teeth that were an issue, and now you're kind of turning it into a 4th tooth problem. And if you look at the radiograph, those laterals, they do have nice long roots. They've got, no decay. And this is a situation where, we're looking to try to minimize the amount of trauma we're doing in patients' mouths. So I don't think the doctor that submitted this is on the wrong track here. I think you certainly could have gotten away with a bridge, but even a bridge in this area, how much soft tissue or hard tissue augmentation, you're going to want to do something anyway to bulk out the area. And so I think it's key that we kind of think about that. What are you looking at here? What are your thoughts on, first of all, the internal resorption? You can see it on both teeth, actually, kind of starting on that number 24. But look where the bone peak is on 24 too. At least in that one view, it looks worse.
Yeah. And on, after the extractions, the bone peak on 26 doesn't look great, but it looks much better on 23 for sure. And,
look how much soft tissue you can see also,
What's that?
You can see a lot of soft tissue, which you normally don't see on X-ray, but you can almost see the thickness.
Exactly. So, I think, the times where I do extraction and let things heal before doing the ridge aug are really in times of where I need vertical augmentation or in times where there's gingival recession, because it's basically times when you're deficient of soft tissue. And I think this case really not a bad call. This is one for that for sure.
So this is how the site looks before GBR. And, as a periodontist, what I'm drawn to is the calculus on the teeth, which obviously is very common in this area of the mouth. And I think it's so important. And whoever submitted this case did a great job. You'll see in the next photo that they did, clean the area. So that's very, very important. But we're stuck here looking at a defect that's, not only a vertical component that we saw from the x-rays, but clearly, quite a soft tissue defect. And the way this was treated, you'll see here, this is the pre-op of the GBR. This was actually treated with a tenting screw. So this person obviously follows Israel on Instagram because he knows that, in order for us to maintain that vertical height, we need some sort of space maintaining device. I think I've seen a case of yours very similar to this, where you use that tenting screw beautifully. I noticed here, this is a true tenting screw. It doesn't have threads all the way up.
Yeah.
You like to use the threaded tenting screws most of the time, right?
I do. Honestly, when I've used tenting screws, I've actually had them break sometimes where they break at the junction of the threaded and non-threaded, the threaded and the lag portion of the screw. I've had them actually snap right at that spot as I'm screwing it in. And I've not had just a full threaded fixation screw snap like that. So that's what I use. Although I like this tenting screw, I like the width of the head because it kind of shields. It's not quite as narrow and comes out like an umbrella. So it lets the soft tissue kind of lay with more support. So I do like that. But my personal preference, I like to use the full threaded fixation screws, but you can't go wrong if it works.
And what you see here, though, which is really the question that was asked by the doctor is, how much hard tissue, soft tissue am I degranulating? And the truth is it depends on the case. Every single case is going to be different. And it is a good time to use very, good magnification, good loops. You really want to remove any soft tissue remnants. They did a very good job of a full thickness flap. You can see the bone beautifully there. There's no remnants of any soft tissue, but it does look like they did quite a bit of degranulation. And, it's hard for us to judge that because we were not there. So we don't really know. But that's a critical point, is you really don't want to remove supporting bone. Any bone that's holding, for instance, that occlusal height is going to be very valuable. And with that, you can avoid potentially using a tenting screw. But I'm going to give the benefit of the doubt here and say, maybe that bone was really, really soft. And I will say, in those cases where I do wait to go back, let's say I'm not going to graft at the time of tooth extraction, I'm typically going to wait a little longer than 2 or 3 months, just because I hate this scenario. I hate not knowing what's in there. So
the key is also to, when you do the extraction, to make sure you completely degranulate everything, so you can really feel a little bit more secure that anything that's left after that 2 or 3 months is, if it's soft, it should be soft bundle bone, growing bone. It shouldn't be real granulomatous tissue left over from the extraction sites.
Yeah. And I'll say here, it's hard for us to tell if they use PRF here or if it's just autogenous scrapings, but a great area to just be able to harvest some autogenous locally. I like the incision design in regards to the fact that we know where the mental foramen is, and having that access having those verticals is going to allow you to get primary closure. I would say maybe I would have placed them a little deeper into the vestibule. But look how that bone is staying so nice and tidy there. So I'm guessing there was just a good amount of autogenous there, or maybe even sticky bone. Doesn't quite have that sticky bone shine, but it definitely is in there nice and stable. And let's see where we went from here.
Cover the head of the screw, add a lot of bone. I have a feeling this person took our course.
And a beautiful, beautiful job suturing here. I love the dual layer, especially because we had that buccal and lingual component. But I have to say, Israel, I do a lot of stabilizing sutures, as you know, but the majority of my cases have always been, horizontal. And when I get that vertical little defect, I tend to go back to maybe using, screws, tacks, maybe even a more reinforced membrane. You actually showed me that, hey, this is a good combination. Go with the stabilizing sutures and a resorbable membrane, but you still need better space maintenance. So combine it with that tenting screw.
Yeah, you definitely need something non-resorbable, or something that'll give you much more physical support, so you won't have collapse of defect that you get more so with a vertical deficiency than a horizontal. Just gravity is going against you over here. So I love the combination of using resorbable materials, but still having that structural support of the tenting screw. I love that.
And when we're using a resorbable membrane, we're so tempted to take like one big piece and try to cut it so it's like a trapezoid, so it kind of folds over the crest, but it's never enough. It's like never large enough. So I love this doctor here took piece and clearly tucked to create almost like a lingual wall to pack into, and then has the piece on the buccal. We're using mostly resorbable sutures for these mostly horizontal defects nowadays, but the truth is PTFE, you can't go wrong. 3.0 PTFE, very tissue friendly. It's going to be there in 2 weeks, so it's doing what it's supposed to do. It looks like they have pretty good dual layer closure here. For me, probably more sutures than I think is needed, but it looks pretty good at this point, I think.
Yeah, I agree. I might go exactly like you, a little easier on the suturing, but and use Glycolon. It's just a little more tissue friendly, I think. Finer suture, but
And I'll admit it, I'm getting lazy. And for me to be able to have sutures in there and know that I don't have to be digging them out at 2 weeks or 3 weeks, it's a huge advantage. All right, well, here's the last photo we have, but all signs point to us doing pretty well here. You can just kind of use the tenting screw as a reference point of that height of bone. So they're in a pretty nice shape. Now, one thing I'll say, it's a little tough. You're placing that tenting screw right in the center of that edentulous space. And the plan is to place one implant with a cantilever, which I think most of us would agree in this area of the mouth, great way to go. Just for aesthetic purposes, if nothing else. This is a pretty large space though. If you're looking mesiodistally, it is a pretty large space. So you might have been able to get away with 2, but now you have that tenting screw right in the center. I almost wonder if, that could sort of get in the way. You ever find that when you're removing the tenting screw, you lose bone with it? Maybe some of the bone's a little immature and you kind of create bigger defect than you'd like?
Not often, but I could think of one case where there is, I don't think I've ever shown this case, but it was upper left area and grew a ton of vertical bone. And thankfully on the Jason area was more bone than what I thought I would get. So I actually had to end up removing some of that bone to make things level. So yeah, it can happen. The bone can be a little soft, especially if there's a little exposure of the screw head. But it looks like over here he definitely grew enough vertical height to get a good result. So
yeah, and I think for me, like the lesson of this case is basically the way we started this case is like, do we always need to extract and graft at the same time?
Right.
And the answer is sometimes, you can't go wrong by letting the body do the work for us and not forcing the issue. And so that's something I think we should consider in every one of our cases.